All right. Good morning, good afternoon, good evening, whatever time that you're listening to this podcast. I would like to welcome you to our first African Leaders Council podcast, She Speaks. My name is Matilda Lucas, and I'm going to be your host today. We are so excited, and we are starting it with a very dynamic topic. My guest for today is Ms. Shakana Hall, and today we'll be discussing the main causes of maternal death among Black women. Shakana, welcome.
Thank you for having me.
Great. I am so excited. And for those who may not know, I will give a brief introduction about our guest, but just a little bit on the topic. Black women in the United States experience maternal mortality at 2.6 to 3.5 times the rate of white women. So we will be discussing this, and get ready, call your friends, text them if you're listening to this live, or share with them if you're listening to this later on. This is a topic that you don't want to miss. So a little bit about our guest, as mentioned before. Her name is Shakana Hall. She's a nurse practitioner, born and raised in South Florida. She attended Alabama A&M University and is a graduate of Florida A&M University, where she did her nursing program. She's worked in Central Florida with a local hospital organization for over 25 years. Shakana, I can see you want to jump in. I said, let me introduce myself. So
No, you're good.
a little
You're
bit
doing a
more
great
about
job.
Shakana. She's a registered nurse and nurse educator, birth coordinator, and nurse executive. Shakana has provided healthcare to Medicare, medical, surgical patients on ventilators, diabetes, orthopedics, stroke, heart, and HIV patients. In addition, she has cared for pregnant women as they welcome their newborns in the world. Shakana is also a trained adult oh my goodness, I cannot speak. Geriatric primary care nurse practitioner who cares for patients from puberty to end of life. Shakana, welcome to the program.
For having me.
Thank you. So we will go ahead and dive into this topic, as it is heavy, and there are a lot of questions that we'll need to want to cover or have answered. So let's start with the root causes and clinical challenges. What shocked you the most about the racial disparity in maternal mortality when you started your career?
So thank you again for having me. One thing that really stood out to me was, well, first of all, I was like, wow, unbelievable. For United States to be one of the largest and richest country, and we have so many resources and education at our fingertips, but yet we still have women dying after giving birth. But we have some work to do, because we have 3 high-income countries, just like United States, that are doing a phenomenal job. So for instance, Norway had 0 out of 100,000 births for a mom to pass in 2022. Switzerland had 1 per 100,000 mom to pass after giving birth. And Sweden had only 3. So why are we the largest country, have all of these resources, have trained healthcare providers, and we have the most deaths? Another thing that stood out is 2019. That's just 6 years ago. We, as United States, were 35th out of the nations for having deaths. And then 1 year later, which is 365 days later, in United States rate 65th in the nation of having women die after birth. So those numbers are very staggering, and it's time now that we do something. And we're going to have to start doing it within our country and within our community until everyone else get on board.
Yes, those numbers are very shocking. And America being as developed as it is, it makes us stand aside and say, is it really true? I'm glad we've had people like Serena Williams talk about this when she went through her experiences, and also, unfortunately, the passing of that athlete, Bowie, who at 8 months passed away from maternal complications.
So some of the cardiovascular things that do contribute to delay of care that is often missed is, one, we have to understand the heart. So during pregnancy, when a woman becomes pregnant, the blood vessels actually pump more blood. The ventricles actually has more blood going through them. The heart flow is increased. And most importantly, people don't understand is that your heart size changes. It increases and it will get larger and shift to the left. And so most people don't realize that. But if we take a stance and say, prior to pregnancy, let's try to get ourselves healthy, that would also help. So we can talk about that in a few. But some of the things that are missed is that you will find where pregnant women will say, I'm tired, I don't feel good, I'm going through the motions, I feel like I'm a little swollen. And you have caregivers and spouses say, oh, you're pregnant. That's why that's happening. But they also can be after delivery and they say, I'm tired. I have a headache that won't go away. I need something. I tried to sleep. I can't sleep. My head hurts. But as caregivers and spouses, we'll say, you just had a baby. Go ahead and lay down. Some of the signs that are missed and avoided or families do not act upon it is a headache that won't go away. You took Tylenol or Motrin and it's still there. And then it become a pounding headache. That means your blood pressure is going up. Some people would lay down and they will have a seizure. Some people lay down and would not wake back up. You can have blurred vision. You can also have upper belly pain. And with the upper belly pain, you're like, oh, my belly hurt, or just feel funny. I don't know what it is. And the majority of the time, that's also one of the signs that are dismissed during pregnancy and after pregnancy. So I say the key things is your face can swell, your lip can swell, your hands and your feet. We know that happens because everything is getting a little bit larger. But when it's abnormal, and it continues, you have to speak up. So you'll look for that. You look for the blurred vision, light sensitivity, or sometimes you will just, I don't feel well and I can't put my hand on it, especially the upper belly pain. All of those classic signs are cardiomyopathy, where the heart is increasing and it's shifting. But it's also signs that can lead to having a seizure, a stroke, and pregnancy. And so you have to know, you listed all of the signs, which is great. But then also is, I took a nap. I slept 4 or 5 hours. I got up. I fed the baby. I was able to sleep again because I have help at home, but I still feel exhausted. You want to know that's a red flag. So you start thinking, what was my hemoglobin before I left? How much blood did I lose? You know, they tell you the generic, but now most of the hospitals have an app where you can look at your lab work. And that way you will know the difference between when you started, when you were pregnant, and then when you finish. So those are some of the things that you have to look for. But most importantly, what has changed a lot is we have a lot of women and spouses, husbands, wives are not going to prenatal class. In prenatal class, you get some of that information. In the hospital, they will share some of that information. Some people have a discharge book, but most importantly, it's best that you have a caregiver or spouse or someone who also can be your advocate, because they would know what was normal prior to delivery. They would know how it was during delivery and then especially afterwards. So it's two things. And the first one is actually when you, as a pregnant person learning, we always have to figure out how long would you be able to stay home after the baby? Do you have to go directly to work afterwards? Who is going to be in the house with you? And whoever that person is, and it could be two because they can take turns, but whatever you learn during pregnancy, you have to also teach them. So that means you have to break it down to layman's terms. Sometimes if you don't understand when you go to your provider, you have to ask them, can you draw something for me? I'm a visual person. Can you show me differently instead of talking to me? So those are the different things. But we also have to remember that back in the day, the older ones, as we have our girls, and our girls are learning their cycle for the first time. Guess what we do? It's like, you're going to get a cycle. This is your pad. Put it on. You're going to get cramps. This is what women do. You'll be okay, and you suffer through the pain. But we don't teach them step by step, but also teach them this is what cramps are. This is how you should feel. Let's try to take Motrin, something very light for them the one time. But it should not continue. Cycle hurt, but cycles and menstrual cycles every single month is not normal when they're painful. But we have to start teaching them at a younger age. So you can have a cycle. It's going to be very difficult in the beginning. We're going to teach them. We're going to show them how to take care of themselves, keep them healthy. But also we need to let them know that you need to stay up front with me, because your cycle should not be very painful all your life. The first 3-4 months, it will be painful because we get used to it. Correct? Yes. So personally, I do not feel that providers go to nursing school, social work school, get your degree, or even also doctor. I don't think they go to medical school wanting to harm people. I don't think that's the reason why they go. I think what happens sometimes is we all learn the information. And as you finish school, you want to do your best. Your job is to save lives. But you would say, and this is from years from learning, that I took care of this Black young lady. She endured childbirth fine. She didn't scream. She didn't holler. The pain was okay. She tolerated well. And then we have someone else who's also Black or people of color. They have a totally different experience where they will scream and holler. And then all of a sudden it is, why are they doing this? This is not the person who I took care before. But the goal is we're supposed to teach and treat and care for everyone as differently and according to them and their body. But over years, people get overworked. They are balancing everything in the hospital. And then they're also doing shortcuts to make it in and to see everyone. And that's what needs to stop. So when you talk about going from pregnancy to during delivery and postpartum, and they have various providers, you might have a provider who is a single provider. So they're going to see them at delivery and they will see them postpartum. They will make their appointments and they will come back to see them. That particular provider knows everything about that patient. But what's happening is all of the ones that you're meeting are not going back and reading your pregnancy, things that have been happening for you from the beginning. They're going to see you for that day and treat things that we need to do. And they become more task oriented. Fast forward after delivery, now you have a different provider, someone in that group who is now seeing you postpartum. They don't know what happened to you from pregnancy to delivery. They can read a delivery note, but they do not know your overall. So I truly believe that's what happened, and that's how things are missed during the pregnancy, labor room, and postpartum. And so that's why we have to do a better job and also learn what works, what don't work for our body. And we have to learn keywords to share with them so we can advocate on our behalf. Yes. Yes. So we have a growing number of hospitals that actually are bringing on more and more midwives. So I did mention the statistics for Norway, where they had zero, and I repeat, zero maternal deaths per 100,000 deliveries in 2022. They use majority of midwives. So they have providers, they have doctors, and they have midwives, but the majority of them were midwives. And so you will see in a lot of hospital settings, they are now bringing midwives in. You still have midwives that are in their private settings. The only thing with that is if you have to have a stat C-section baby get in trouble, they have to call 911 and take you to the hospital. So now the hospitals are trying really, really hard to bring on more midwives to help them through the process. And you do see doctor's office bringing on more midwives for delivery. So if they continue to do that, the midwives are more personal, take their time, develop the individualized plan for that particular patient. And I believe in that way, we can start having more and more lives being saved. And it could be, so you are correct, that could be a sign. But the regardless is that we do still have people of other races that have hemorrhages, that have preeclampsia. And so they have a plan. So the thing is, if their plan work, even though it's for a different nationality, why can't the U.S. adapt some of those plans? Because that would still save lives. So you are correct. Norway do have, no, I said you are correct. Norway do have the majority of Caucasian and others, but they do have processes that if you have high blood pressure, this is what we do. If you start hemorrhaging, these are some of the things we do. So it is, even though they do have that, so in the majority of the time you have a vaginal delivery, when you stand up for the first time after giving birth, you have a full gush of blood that comes out. It's normally at your feet on the floor. That is a normal process because you've been laying flat. So it's just actually just pulling, sitting there. When you stand up, it comes down. After you go to the restroom for the first time and the nurse help you in the restroom, after that is when the clock starts again. Put a pad on. If you are soaking a pad within 1 hour, then that's starting a hemorrhage protocol. You can actually put a pad on and then you can start having some type of bleeding. And it might not be forceful, but you could have continuous bleeding, drip, 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 drip. That is also a sign of hemorrhaging can be starting. And then also if we go to the restroom, if you passing clots size of the quarter to an egg size, those are red flags for hemorrhaging. This is why when we start educating ourselves, we have to educate our caregivers who's going to be home with us, who can also be our voice, or we're educating the caregiver who is going to be that point person in the labor room with us. So I believe everyone, absolutely. And they should be. And so until the United States can do everything possible to save African Americans and people of color by giving birth, you should have some type of fear. But if you're knowledgeable, you have the advice, and you always have, when you are voiceless, you have someone there who can be your voice. That's going to give you a little bit of hope. But the hope is going to start back with educating our people that's with us, and also knowing the complications and risks that go along with giving birth. That is really the most important thing. So I'll say one of the things is you can pick a topic. You're pregnant, you have 8 months, but I would say 8 months instead of 9, but you have all these months to prepare, or either prepare beforehand. So the hope is that we are going to have more platforms like this. We need to be more visible in the community, and we need to make sure that we gather our pregnant ladies together and educate them what they need to know. So when they go into the different places to deliver, they know what to expect. They always have someone there who can speak on their behalf. And if they cannot get the answers that they need or want, then you always say, this is what people don't know. You go to chain of command when you're in the hospital. You talking to that nurse, you feel as though that nurse is not listening to you, then you got to ask to speak to who's in charge. That charge person come in and you feel like she's not listening to you, correct? Red flags. And everyone is going to put us like, we better watch her because she knows a little bit more. You have to use keywords. That's why we have to join forces and teach and educate as much as possible. And then we have to have the right mindset. And the mindset is childbirth is risky. Childbirth is dangerous, but I am equipped and I am ready to conquer this. We're going to go and learn and this is a different topic, but even teaching CPR. So when your baby come home, you are equipped for that baby when that baby choke or stop breathing. So that's something separate. But we have to now start being equipped, knowing when to call 911, chest pain, shortness of breath, difficulty breathing, blurred vision, can't see. We have to now start equipping ourselves, teaching and learning. So those are some of the things. But when we change our mindset and know that we are going into a risky situation, but we must be armed and ready to have a voice, because having a baby should be safe. That should be a right and not a privilege. So we have to make sure that we arm ourselves, equip ourselves, and we prepare. And then that way we can come on the other side, because the goal is not for dad, for them to have a marriage, get pregnant, and dad raise baby by themselves. The goal is for them to leave that hospital together as a family and to stay a family and to continue. Because even though you leave the hospital, preeclampsia, they talk about it during delivery and pregnancy, but it can last up to 12 weeks after delivery. So even though you might have it during pregnancy, it can last up to 12 weeks after delivery. So even when dad, mom, the family goes home, this is still day one of going home. But day one, we still need to have everything. We need a blood pressure cuff that wraps around your arm, and have it at home. You have that headache, you're going to put that cuff on. You need to know the baseline. You need to also, and I'll tell you this too, my book is coming out this fall. So we're going to talk about that. And it's actually about this. And I am so excited, but this is going to equip our readers, our learners, our viewers on what they need to know when they get home. And my book is entitled, You Will Live: 7 Strategies to Be Well and do what? No, I said it wrong. 7 strategies to thrive and be well after delivery. So the goal is I'm equipping you and giving you the information that you need. But most importantly, I'm going to teach you 7 strategies that you need when you get home so y'all can stay one as a family. And that is during delivery and at home. So we're going to talk about that. That's another show. But I'm so excited. But the goal is, yes, the goal is we started now, but we're going to continue because we have so many dads that need their mom, their baby, the wife. We need our mothers home so they can be one as a family. Thank you for that question. So it starts also prior to getting pregnant. If you have a history of anxiety prior to pregnancy, you have at least 9 out of 10, it says research, that you probably will develop postpartum depression or anxiety during your pregnancy. So that's one thing that we do know. So if you already have it prior to delivery, getting pregnant, you need to have an honest conversation with your provider so they can change your medicine and give you the right medicine that aligns with the baby, that doesn't cross the placenta, and that can keep you sane and safe mentally going through the pregnancy. Then afterwards, and even during it, you will notice sometimes you can be, I just don't feel like doing anything. Baby can be crying and you do not respond or react. That is some of the signs that can go to postpartum depression. Now, having the postpartum blues, I'm sad today, happy tomorrow, sad for a couple hours. This evening, I feel so much better. I need to just cry it out and it's done within a week, then that's normal. But if it continues, then that's one thing you need to see your provider ASAP. So when you leave the hospital, you do have some doctors that say, see me in 6 weeks. Well, that's the old days. See you in 6 weeks, I can be dead in 6 weeks. So they do have some research that has come out that say, if you have a C-section, see me in 1 week. I can look at your incision, but I also can go over, talk about postpartum depression, talk about anxiety. How is your bleeding? How is your breast? Are you breastfeeding? So they can go through all of that at the 1 week. That's the safest route, and check your blood pressure. And then also vaginal deliveries, they've been bringing them back about 2 weeks. And that is the same thing, to go over postpartum depression questions. What about anxiety? You're now home. Things change. Or you could be going home as a single mom. You don't have help. You can only sleep when the baby's sleep. But when the baby's sleeping, now you're changing, washing, and you're doing things like that. But you're going to have to adapt to baby. I tell everyone, when baby sleeps, you sleep. Text everyone, call your family. Baby is sleeping. We're going to take a nap. The phone, we're turning off. We'll turn it back on when we get up. You have to know your signs and symptoms prior to. And then do not be afraid to talk and to share that. And make sure you call your doctor back before you get back and say, I need help. Good. Yes. Thank you, Valerie. So eclampsia, it can start in pregnancy. And so it can actually go through up to 12 weeks after delivery. So with that being said and you may not have preeclampsia during pregnancy and develop it afterwards. Your blood pressure could have been on the borderline all during pregnancy. Baby is out, hormones are shifting. Now that blood pressure is starting to go up, up, up. It's best to address it while they can in the hospital. Sometimes they will start PO by mouth medication. Sometimes you might have to get IV, magnesium sulfate, to help you. But it can last up to 12 weeks. So baby will be 3 months old and you still could be going through preeclampsia, post-eclampsia. So we have to be mindful of that. The studies actually say that if you have preeclampsia during pregnancy and you subside and you go through it and you're done with your medication, by the time you're 40s and 50s, you could develop and have hypertension. So that is the new research that's happening, that if you are preeclamptic during pregnancy or have preeclampsia, have high blood pressure, and you go through that, you are now predisposed to have hypertension when you're older. Same thing with diabetes. You would do a 3 hours also to check your blood sugar. If you are a diabetic during pregnancy, you have 9 to 10 out of 10 chances of becoming a diabetic later on in life. So that means we have opportunities to take care of ourselves, change our diet, and eat better so we can not have those types of disorders, diseases. So there's not age do have a factor. Okay. What I don't like now, if you're over 35, they call you elderly now in the hospital. And I don't like that word because you have people that have babies like, exactly. But if you are older, you're having a baby, remember now, even prior to not having a baby, we're older, our hormones change, blood is thicker, is running, is all through your body, you do have a higher risk of having diabetes or preeclampsia. Because even if you're not pregnant and you're older, we have that risk because everything we ate prior to, everything that we have done prior to for our heart, not conditioning it, not exercising, and then now you have a rush of extra fluid and your blood pumping. So you do have a risk. Now, when you're younger, we still have younger individuals that are preeclamptic. I have had an 18-year-old that was preeclamptic that had a baby. And it just all depends. She did not have high blood pressure prior to, but during her pregnancy, she developed it and along also afterwards. But it's our BMI, which we don't like, but it's true. If we're overweight, that can also increase our ability to have preeclampsia and eclampsia. You're right. So thank you. Initially, they do transvaginal ultrasound. So the goal is a lot of times if you find that you're pregnant 6 weeks, 7 weeks, 8 weeks, they would do a lab test, HCG. They want to see how high it is. But at that time, they can't do a transvaginal because if you do a regular ultrasound on your belly, you may not really see or hear or get a great reading from the heart rate. So when you're less than 12 weeks, sometimes up to about 16 weeks, they can do a vaginal ultrasound. As a Black mom, and also I have family members too that's pregnant or just had a baby. The hope is that we have to learn to save ourselves until everybody is on board. And one other thing for hope I do like is that a lot of the hospitals now are also educating the emergency department. So if you are home postpartum and you have that headache, you don't feel good, they are now educating the emergency department. But one thing that we can do too is we come back in and the spouse tell you, because sometimes if you have the light bother you, you can't keep your eyes open, blurred vision. It is, this is my wife. This is my family member. She had a baby 2 weeks ago. We had a baby 7 days ago. She had a baby 10 days ago and her head will not stop pounding. I think she might have preeclampsia. I think something is wrong. Please save her. But it's when we start learning the key words, then we can also share it with others. But the hope is there. We have community people, organizations that's trying to get the word out, educating. But I also need you and all of our moms and families to do their part because no one is going to help us. We have to start helping ourselves because when it's a global problem, it takes a lot of resources and time. And right now we don't have time to wait for others to take care of us. We have to learn the key words. We have to be ready and we have to make sure that we go in all force, knowledgeable, have that understanding. And so we can save ourselves at this time. Yes. So that is everywhere. The majority of people that you see, unfortunately, a lot of times in hospitals are Caucasians. So the ratio is off. But the good thing is that while you're there, majority of the time you may see 1 or 2 Black. And so you have to make sure you connect. I can say that a couple of local hospitals are still reaching out to various African-American universities so they can come and partner and also do their residency and stay with the hospital because that's the goal. So they are trying to strengthen the African-American people of color population as employees. You will go there and there are times I had a patient that say, "You're the first one I saw that looked like me." And I was like, "Really?" And it's day of discharge for her. And she was just so happy. Her and her husband was so happy to see me. Those are the days that we have to stop that from happening. But it goes back to who is hiring. When I was a manager and a leader, I strategically, and human resources would laugh at me. I was like, okay, I hired a white person. Now I need a Black, I need Hispanic, and I need someone else. And she was like, you're so crazy. And I'm like, nope. So for me, I was very, very intentional. And my unit was, and that was from learned behavior. And I know if I'm not here as a leader, I need someone else to represent me. And when you teach your team, you have to teach about culture. We have some sayings that we would know. You can be coming down the hallway, you would hear someone clicking. I know that there are some patients that are Black that click, and that's their part of pain. And when I'm walking down the hallway, I see someone clicking, let me go check on them, because that's the way they tolerate their pain. Then you have some that do various things, but that is something that was taught to my team. And that's because I was very, very intentional. We need to have more leaders like that, who's going to lead with compassion and also leads with intentionality. So I can't say for sure what each hospital will have. I can say that there is change coming. When the change is going to come, I don't have the exact words, but I will always say stay prayerful and make sure you stay positive. And so you have to know the goal is for you and baby to go home safe. So you're going to keep the eye on the prize of the baby. You need a safe delivery, but you're also going to have whoever's in your room is not chit-chattering on the computers, on the phone, watching TV. Is I truly need you to be intentional and be my voice when I'm voiceless. Yes, I am seeing patients, but not in women care. So I worked at a local organization 25 years last year, and I actually transitioned over to Johns Hopkins, which is a part of occupational. Yes, thank you. So occupational nurse practitioner, but I still have women. So actually I have 4 of my employees that are pregnant that will come and see me and ask questions and bounce things off. And I help create a little plan for them. But right now, no, but my heart is here. My passion is here, and it is not going to go away because we have so much work to do. So yes, I'm seeing other patients, but my heart is here. This is what I'm still working for. This is what I'm doing in the community. I actually made a couple postpartum baskets. So we sold a couple of those. Yes, yes. So some of the postpartum blankets. No, go ahead. So the goal is, at one of the baby showers, we actually talked about how the kit works, and we had everyone, go through their gifts. But at the end, I went up to say, thank everyone for coming. This last gift is for the mom and the dad. And this is a postpartum kit that she would need. So we went to like table by table. You're here on behalf of dad. If dad say that I need you to learn key words. If the dad say she's been resting, she says she feels so tired. What's she doing with a headache that won't go away? Man, do you know you're supposed to call the doctor? You're supposed to do this. Because the goal is you love him and you love her, and that everybody is here for them. The next one is you go to another table. You're the mom. You're going to be in the delivery. You're going to be home. These are the things that you need to know. So we will educate each table, tailor it to what they need. She can go back to work at 6 weeks. Well, her close coworkers are there. You need to know these signs, because if she's there working and she's so tired, and she talks about this headache, she talk about the upper belly hurting, she talk about she's still swollen, her feet, and now you notice her mouth, those are red flags. We're calling 911. So it was really tailored to everyone at the baby shower had a task. And the task is to keep this family whole so they can go home together and stay together. Thank you. Yes, I would love to reach out. Yeah, so my book is called You Will Live: 7 Strategies to Thrive and Be Well During and After Birth. So it will be coming out this fall. My email is info@hwpcsolutions. And you can reach me at 407-803-37. If you have questions, you can text or call. But most importantly, we're going to stay and remain partners. And I'm here to help anyone. Also, advocacy, I can come out to the different hospitals to help advocate on your behalf. And then I also can teach you how to advocate on your behalf. So I have various services, but I'm here to help you to stay safe. The time is now, the time for us to take back our families and to do something to save lives. Yes, I do. Thank you.